Now, we remember our last slide. Let's check that that's where we were. Is it the case? Where you can confirm?
Yes,
this is the last slide that we were.
Okay, so we can move to the next. The next there, we are looking at, we are just continuing the sentence, and therefore you read it, you read the slide yourself. That's just a general remark. Where you are reading.
Optimal drug absorption requires a balance of lipophilic and water solubility, which is why many drugs are weak acids or bases. Very hydrophilic drugs can't cross lipid membranes, while highly lipophilic ones are poorly soluble in body fluids. Chemical stability. Some drugs such as penicillin G are unstable in the pH gastric contents. Others such as insulin are destroyed in the GI tract by digestive enzymes.
Not where, please. And soma tu yenye iko. By degradative enzymes. Fine. I think you understand that. That was just a general remark. But these general remarks here have the application in real life. For example, when you look at some drug that we have just said, for example, insulin, due to this fact, we don't have an oral formulation of it. We only have injectables, because if you give it orally, it will just be destroyed by the action in the GI tract. I think that sentence of most drugs are weak acids or bases are already said, because strong acids and strong bases ionize completely, and therefore the absorption capacity reduces. So that was a general remark. Next sentence, next slide is about bioequivalence and other types of equivalence. So the word is bioequivalence. Anastasia, read that. Hello.
Bioequivalence and other types of equivalence. Two drug formulations are bioequivalent if they show comparable bioavailability and similar times to achieve peak blood concentrations. Two drugs formulations are therapeutically equivalent if they are pharmaceutically equivalent. That is, they have the same dosage form, contain the same active ingredient at the same strength, and use the same route of administration, with similar clinical and safety profiles. Thus, therapeutic equivalence requires that drug products are bioequivalent and pharmaceutically equivalent.
Thank you. So just to recap that slide, the first sentence is saying two drugs are bioequivalent if they show two things. And the two things are comparable bioavailability, one, and two, similar times to achieve peak blood concentrations. In other words, if their bioavailability is 0.7, they are both 0.7. Then if they reach peak concentrations in 2 hours, they both reach peak concentrations in 2 hours. If those two characteristics exist in terms of time to peak concentration and bioavailability, and they're exact, then we say the two drugs are bioequivalent. Then the other form of equivalence is what we have called pharmaceutical equivalence and therapeutic equivalence. So in summary, what are the three types of equivalence we are talking here? We are talking about here. It is bioequivalence, therapeutic equivalence, and pharmaceutical equivalence. Bioequivalence has two characteristics mainly. The drug is comparable in terms of bioavailability and time to peak concentration. Two is pharmaceutical equivalence. Pharmaceutical equivalence means the drug has pharmaceutical characteristics that are similar. For example, dosage form, active ingredients, strength, route of administration, clinical and safety profiles. So when we have those 6 items similar, then the drug is pharmaceutically equivalent. Now, if the drug is having 2 similarities, one, bioequivalent, and 2, pharmaceutical equivalent, then they achieve the third level of equivalence called therapeutic equivalence. I think we can move to the next slide. So the next item in pharmacokinetics is drug distribution.
Can you display the previous slide for screenshotting, please?
Okay, you're screenshotting, no problem.
Thank you.
Okay. Drug distribution. So drug distribution by definition, let somebody read. Abigail, are you there? Okay. Ordinarily, let me ask. Okay, sorry. Okay, Abigail was preparing, or somebody was preparing. Kindly read.
Drug distribution is the process by which a drug reversibly leaves the bloodstream and enters the extracellular fluid and tissues. For drugs administered IV, absorption is not a factor, and the initial phase immediately following administration represents the distribution phase, during which the drug rapidly leaves the circulation and enters the tissues. The distribution of drug from the plasma to the interstitium depends on cardiac output and local blood flow, capillary permeability, tissue volume, degree of binding of the drug to plasma and tissue proteins, and relative lipophilicity of the drug.
Thank you. Just to recap the slide again, by definition, first of all, when a drug is absorbed, where do we want it to go? Ordinarily, it's first to reach the bloodstream, systemic circulation. Then from there, it can go to the areas where it functions. Now, we have said that IV drugs absorption is not a factor because for them, once we are administering them the bloodstream. So from the bloodstream, they see to extracellular fluid and the tissues where they act. So this is from that, we are getting the drug from that original site of package, is the bloodstream, tissues and the extracellular fluids. Now, what are the factors that influence how fast the drug leaves the bloodstream? When you talk of cardiac output and blood flow, those can be summarized in one thing, is just blood flow actually. Capillary permeability, tissue volume, degree of binding of the drug to plasma and tissue proteins, and relative lipophilicity of the drug. Now, when you look at blood flow, which one makes for a faster movement? Is it fast when the drug flow is high or if it's low? Hello?
Hello.
Which one makes for a faster redistribution when the drug blood flow is low or high?
I think when the blood flow is high.
Good. That will make the movement faster. How about capillary permeability? If the capillaries are more permeable, they easily allow molecules to pass through or not.
They allow molecules to pass through, so the
Okay.
mu will be high.
You sure? Good. And how about tissue volume? I think that's debatable. We can't just pass one sentence. Degree of binding of the drug to plasma. If there's a high degree of binding of blood to plasma and tissue proteins, how will the distribution be? Faster or reduced? Hello? Any thoughts about that?
Okay, when the degree of binding of the drug to plasma and tissue proteins is high, I think the distribution of the drug will also be high or reduced.
Okay, let me give a small, like within the plasma, we have a protein called albumin, which largely binds a lot of molecules. Now, if this albumin is binding tightly to the drug, will that drug quite easily leave the plasma to other areas, or it will stick within the plasma? Hello?
Yes.
Hello.
Ni kama unapeleka mzigo mahali halafu unapea mtu achunge na anakwamilia na unataka itembee kwa watu, si unaona akikwamilia itakwama hapo pahali amekwamilia. So we get the answer that follows with that.
Yes.
If the binding is so tight, then the distribution will be less. How about lipophilicity of the drug? Now, drugs that are more lipophilic, they tend to cross the plasma membrane more easily because the plasma membrane has that lipid bilayer. Drugs that are hydrophilic don't easily pass the plasma membrane. Instead, they must go through the slits within the membrane. So if the drug is highly lipophilic, then that drug can distribute so quickly. Hapo tuko sawa?
Yeah, hapo tuko sawa.
Now let's move through the slides that actually explain this. Mika, you are speaking, so just read that sentence, that slide.
The rate of blood flow to the tissue capillaries varies widely. For instance, blood flow to the vessel-rich organs, which are the brain, liver, and kidney, is greater than that to the skeletal muscles. Adipose tissue, skin, and viscera have still lower rates of blood flow. Variation in blood flow partly explains the short duration of hypnosis produced by an IV bolus of propofol. High blood flow, together with high lipophilicity of propofol, permits rapid distribution into the central nervous system and produces anesthesia. A subsequent slower distribution to skeletal muscle and adipose tissue lowers the plasma concentration so that the drug diffuses out of the central nervous system down the concentration gradient and consciousness is regained.
So that was just an example. Sorry, just finish.
Capillary structure affects drugs entry into tissue in organs like the liver and spleen. Large split junctions allow plasma proteins to pass, while in the brain, tight junctions form the blood-brain barrier, permitting only lipid-soluble drugs or those using specific transporters to enter, and excluding most polar or ionized drugs.
Good. Let me just first clarify. Are we still using the word blood-brain barrier, or how did you use it in your physiology when you are studying in the nervous system? Is it
Yeah, it's
blood-brain
just
barrier?
the same.
It's just the same.
Yes,
My physiology teacher said we can't call it blood-brain barrier, but we call it blood-neuron barrier.
that was your teacher.
Yes, and he was an authority.
Of course, maybe.
So, being an authority, his word is also valid. That we can say blood-neuron barrier. But back to slide 1 and 2, we have seen the importance of two things: high blood flow and high lipophilicity. That they permit redistribution, isn't it? They have just qualified what we already spoke about. Slide 3 has told us about capillary structure. If there are more slits, then more hydrophilic or polar drugs can easily go through. But if it has no slits, like we have the tight junctions in the brain, then mostly it's the lipophilic drugs that will go through. And you know, this is important, like for the brain. I'm sure you're told the importance of the blood neuron barrier, that it helps prevent so much of toxins that would actually reach the brain. Okay. Next. Someone to read?
Binding of
Binding of drugs.
plasma proteins and tissues. Drugs can bind reversibly to plasma protein like albumin, forming a reservoir that shows their distribution and maintains free drug levels. Additionally, drugs may accumulate in tissues by binding to cellular components or via active transport, which can prolong drug effects or cause localized toxicity.
Thank you. I think, as we said, that when there's very serious binding, when there's very tight binding or massive binding, then distribution is slowed. So the binding and distribution have an inverse relationship. And albumin, for one, is actually known for doing that so much. And is also one of the most abundant plasma proteins. Okay. Next.
Lipophilicity of drugs. Lipophilic drugs usually cross cell membranes by dissolving in lipid layers, and their distribution are largely influenced by blood flow, while hydrophilic drugs rely on passing through slit junction due to poor membrane permeability.
So that's important. We have already said that. These were all repetitions, but just the explanations of what we have already said. So the next item there is volume of distribution. Let's read through and try to understand that in a more pay attention to it for us to understand what is going to follow next. Okay, someone to read. Whoever was reading, kindly read again.
So, volume of distribution. The apparent volume of distribution, VD, is defined as the fluid volume that is required to contain the entire drug in the body at the same time, the same concentration measured in the plasma. It is calculated by dividing the dose that ultimately gets into the systemic circulation by the plasma concentration at time 0.
What do you understand that statement? Let's try to understand what that statement means. That the apparent volume of distribution is defined as the fluid volume that is required to contain the entire drug concentration, the entire drug in the body at the same concentration measured in the plasma. Let's say You give a person let's say a milligram of Panadol. If that milligram of Panadol was to be dissolved in the entire blood, in the entire plasma, versus that milligram of Panadol in a fluid like intestinal fluid alone, in which case do you expect the concentration to be higher? Okay, I think that example is wrong. I had some interference here. Let me come back afresh. Let's say you have a drug like that 1 milligram of Panadol, and you are given a small, like a half a liter juice, and you dissolve it in. That a half a liter bottle, and you dissolve it in. And then you are given a 20-liter bottle, and you dissolve it in. In which case shall the concentration be higher?
I think in half a liter.
In half a liter, the concentration will be higher, isn't it?
Yes.
Because generally the solvent is more, yeah, than the solute. Now, what is volume of distribution in this context? The fluid volume that is required to contain the entire drug in the body at the same concentration. So if, for example, in 20 liters, the concentration will be, for example, 5. And the amount of drug is 1 milligram. And we are ending up with a concentration of, for example, 5 or 0 point something, 5 milligrams per liter or per milliliter. What volume will contain the same concentration? What volume of a different fluid will contain the same concentration if it also has only that 1 milliliter, 1 milligram of Panadol? Because the properties of fluids differ, that is why you are likely to have two different fluids having the same amount of the solute, but with totally different concentrations. So volume of distribution is that volume that will have the same amount of the solute, or the drug in this case, and give us a concentration equivalent to were that drug dissolved in the entire plasma. I hope we have gotten that. So if we are looking at, for example, the concentration in the interstitial fluid, we know how much volume the interstitial fluid is. If we put 1 milligram of the drug in the entire interstitial fluid, what concentration will it be? What volume of it will give us, when it has that 1 milligram, will give us the same concentration as though we have that milligram in the entire plasma? And we have a formula of doing it. It's calculated by dividing the dose that ultimately gets into the systemic circulation by the plasma concentration at time 0. So we have that example there. Let's pay attention, because after this you'll do a small calculation. So volume of distribution, we have said, is the theoretical volume relating drug amount to plasma concentration. Now we have amount of drug in the body, symbolized by D. That will be the total drug administered, e.g. the IV dose. And we have the example of 500 milligrams. Then we get the plasma concentration, which is 7.14 milligrams. What will be the volume of distribution what will be the volume of distribution? We simply get it by dividing the dose administered by the plasma concentration. And in this case, we get 70 liters. And at that juncture, I want to see if I have a question there so that you work on. Okay, are you seeing the screen there?
Yes.
Are you seeing question 1.1, 1.4? If you're able to see it clearly, question 1.4.
1.4. Yes, okay.
You see it?
Yes.
If you see whoever has just responded, please read the question through.
It says, a 40-year-old male patient with a weight of 70 kilograms was recently diagnosed with infection involving methicillin-resistant, and that is the name of bacteria, S. aureus. He received 200.
Oh, my friend, you know that name. Microbiology, Staphylococcus aureus.
Microbiology, bado, skip this out.
Okay, sawa, kama bado mtaishika tu.
Okay, let me repeat it. A 40-year-old male patient with a weight of 70 kg was recently diagnosed with infection involving methicillin-resistant S. aureus. He received 2,000 milligrams of vancomycin as an IV loading dose. The peak plasma concentration of vancomycin was 28.5 milligram per liter. The apparent volume of distribution is.
So can we get the response kindly? Let's get the response there. I'm giving you 2 minutes to work it out. Hello? Any response? Newton, kindly speak.
Watu wengi tunapata 1.
Mnapata 1. Unafanya aje?
Volume of distribution is just the dose over the concentration. Then I think the question says per kg and the person is 70 kg. So when you divide 2000 by 28.5, you get 70. Then you divide by that 70, that's the weight. Then you get 1.
Okay, let's confirm. Very good. You get the answer there? So it is 1 liter per kg. Thank you very much. That is very good. Anyone who feels lost?
Yes.
Muli?
I was asking,
Yes.
now when you take the formula, those are administered over plasma concentration, then you divide by, it is 2000 over 28.5. Why
Yes.
should you divide by the weight of that person?
We are getting it is liter, I mean, the volume per kg.
You see, it is 2000 milligrams over 28.5 milligrams per liter. Then the milligrams cancel each other.
It is it is what? You're getting 70?
70.
70 liters.
Yeah.
But what is per kg here?
Oh, by the way.
Okay.
Okay, I get.
So it becomes a liter per kg. Haya, sawa. Kama tuko sawa hivyo, now we proceed. So what does it suggest? Interpretation: a volume of distribution of 70 liters suggests the drug is distributed extensively into tissues beyond total body water. We know the total body water. Hello? Total body water. How is it? What are the compartments that form the total body water? We have the intracellular and extracellular. How much volume is for the intracellular? Are you there? Abigail, Biketi. Anyone who would like to clarify to us the distribution of body water?
I think the intracellular is 67% and then the extracellular is 33%.
That's true in terms of proportions. How about in terms of absolute volume? The percentages are okay. How about the volume?
I think extracellular could be
Okay. The volume is usually between 40 to 42 liters. So intracellular, which is about 2/3, that will be about 26 to 28 liters. Then the extracellular, I've said the intracellular is 28 liters. The extracellular is the remaining 14, of which is distributed between the plasma and which other compartments in the extracellular. Plasma has a volume of how many liters, for instance?
3.5.
Okay, 3.5 or 4. This literature just gives that a small variation there. And then the 10.5 is for which other areas?
Interstitial.
The interstitium, good. So those are the things that are supposed to be at your fingertips. Let's move on. So if we are having a volume of distribution of 40 or 70 liters, we have already distributed to the 42 and finished, and therefore we'll have gone into many other tissues. Okay. Distribution into the water compartments in the body. That's just a general statement. So somebody to read through just for us to move through in passing.
Okay. Distribution into the water compartment in the body. Once a drug enters the body, it has the potential to distribute into any one of the three functional distinct compartments of the body, of the body water, or to become sequestered in a cellular site. The first one is a plasma compartment. If a drug has a higher molecular weight, or it is extensively protein bound, it is too large to pass through the slit junctions of the capillaries, and thus is effectively trapped within the plasma or the vascular compartment. As a result, it has a low VD that approximates the plasma volume, or about 4 liters in a 70 kg individual. Heparin slows this type of distribution.
Next is the same. Just read it through.
B, extracellular fluid. If a drug has a low molecular weight but it is hydrophilic, it can pass through the endothelial slight junction of the capillaries into the interstitial fluid. However, hydrophilic drugs cannot move across the lipid membranes of cells to enter the intracellular fluid. Therefore, these drugs distribute into a volume that is the sum of the plasma volume and the interstitial fluid, which together constitute the extracellular fluid, which is about 20% of the body weight, or 14 liters in a 70 kg individual. Aminoglycosides, antibiotics show this type of distribution.
While we are at that stage, before we move, okay, finish with that first.
Okay, total body water. If a drug has a low molecular weight and has enough lipophilicity, it can move into the interstitium through the slit junction and pass through the cell membranes into the intracellular fluid. These drugs distribute into volume of about 60% of body weight, or about 42 liters in 70 kilogram individual. Ethanol exhibit this apparent VD. Note, in general, a larger volume of distribution indicates greater distribution into tissues. A smaller VD suggests confinement to plasma or extracellular fluid.
Thank you. Just to process our understanding of those three slides, which are general, they are just general remarks that we've already spoken about. Mention a characteristic that will make a drug have a low volume of distribution. In fact, we can have, let's mention two. A characteristic of a drug that will make it have a low volume of distribution. They are there in the slides. So for the screenshotters, please give us some benefit now. Hello? Yeah, say, Patrick, you're saying, well, molecular weight. What do you mean by molecular weight? Like in which case? we need to digest the slides.
What about a drug that has too much a drug that is more acidic, or that is too much acidic or too much basic?
Okay, that is one feature. Although that will mostly influence even absorption, but to an extent, yes, absorption and distribution are quite related. Another feature, yes, Nehemiah.
High plasma protein binding.
High plasma protein binding, very critical there. If a drug is highly bound on plasma proteins, then it will stick within the plasma. Okay, good. Another. Masiga, you are saying, I want you to speak, not just to write. We are interacting. I want to hear the voices. Between molecular weight, high or low, which one will easily move out? High molecular or low molecular? So if it has high molecular, it will not easily move out. Okay? Lipophilicity. If it's highly lipophilic, it will easily distribute. If it's less lipophilic, it will not easily distribute. Okay. So those were general statements. What two features will make a drug be almost evenly distributed in the entire body fluids in the body? We have seen, let's go back to that slide. A drug with low molecular weight and high lipophilicity. Low molecular weight and high lipophilicity. Is it true that ethanol can be all over your body? From the brain to the tissues everywhere. What makes ethanol easily go to the brain, unlike other drugs? Brenda or Gary? Precious, are you there? That lipid solubility. Because we have the blood-brain barrier that bars many drugs, but ethanol is highly lipid soluble, so it will easily, the molecules will diffuse within the lipid layers of that, of the neuronal membranes. And that's why ethanol will easily be able to go to the brain. These things have implications. If somebody has a disease like meningitis caused by infection, a bacterial infection like Neisseria meningitidis, we use antibiotics to treat. This same bacteria, when it causes something else, okay, you're talking of good tissue perfusion. That's true, but what makes the good tissue perfusion? It is that high lipophilicity and low molecular weight. Okay, so I was saying, when we are treating people for diseases like meningitis, meningitis means inflammation of the meninges, and some of the causes are bacterial. mainly actually bacterial, Neisseria, Haemophilus, and this one that causes typhoid is called what? Salmonella. The same drugs we use to treat for these conditions, for example, when they are causing typhoid or pneumonia, we can actually double or triple the dose in terms of treating for meningitis. Why? Because most of the drug will not cross the blood-brain barrier. So we triple the dose for us to get the effective dose that we want. So you find very high doses of drugs being used when you're treating meningitis patients, yet the same drugs, they're used in low doses when you're treating typhoid or when you're treating pneumonia. Okay. Determinants of VD. Somebody to read for us determinants of VD. Or determination of VD, not determinants. Someone to read? Muli, are you there? Dennis.
Yes.
I kindly read.
Determinant of VD.
Determination.
Determination of VD. The fact that drug clearance is usually a first order process allows circulation of VD. First order means that a constant fraction of the drug is eliminated per unit of time. The process can be mostly easily analyzed by plotting the log of the plasma drug concentration versus time. The concentration of drug in the plasma can be extrapolated back to time zero, the time of IV bolus on the y-axis to determine CO, which is the concentration of the drug that could have been achieved if the distribution phase has occurred instantly. This allows calculation of VD as per the formula.
Kindly unmute.
Muli, kindly read.
The slide has gone. Imerudi. Effect of VD on drug half-life. VD has an important influence on the half-life of the drug because drug elimination depends on the amount of drug delivered to the liver or kidney or other organs where metabolism occurs per unit of time. Delivery of drug to the organs of elimination depends not only on blood flow but also on the fraction of drug of drug in the plasma. If a drug has a large VD, most of the drug is in the extraplasmic space and is unavailable to the excretory organs. Therefore, any factor that increases VD can increase one half-life and extend the duration of action of the drug. Note, an exceptionally large VD indicates considerable sequestration of the drug in some tissues or compartments.
Okay. Guys, are we there? Hello?
Hello?
Tuko hapo?
Yeah.
What have we understood as the relationship between volume of distribution, and the elimination of the drug. Is it direct or inverse? Can we be able to say if we increase the volume of distribution, so we hasten the elimination, or if we increase the volume of distribution, we reduce the elimination? Stephen Ouma, are we there?
Yes.
Unasema aje hapo?
So, where is it?
I've just asked a general question.
Okay, I've unmuted. So the relationship between the volume of distribution and excretion of drugs, I think they are just closely related because volume of distribution will influence how much of drug is available in the plasma, where excretion primarily occurs. So if we have a less volume of drug in the plasma, that means lesser drug will be excreted. So I think this thing is just directly proportional.
Okay. Just hold there. Let's go back to the slide here. Just read it.
Kindly bring it clearly to the read mode. It's okay. Effect of volume of distribution on drug half-life. Volume of distribution has an important influence on the half-life of a drug because drug elimination depends on the amount of drugs delivered to the liver or kidney or other organs where metabolism occurs per unit of time. Delivery of drugs to the organs of elimination depends not only on blood flow, but also on the fraction of drug in the plasma. If a drug have a large volume of distribution, most of the drug is in the extraplasmic space and is unavailable to the excretory organ. Therefore, any factor that increases volume of distribution can increase the half-life and extend the duration of action of the drug. Note, an exceptionally large volume of distribution indicates considerable sequestration of the drug in some tissues or compartments.
Have you now understood? Now, when you look at that and the response you gave, any variation, or are they the same?
No, they're not the same. I think this one now bring it to the indirect proportionality.
Yes.
Yeah.
It is like you go somewhere in a stadium as a team, you are 10 of you or 20. Let's say you are 20. And you move around, and then at the time of going, if you are all concentrated in one area, it's quite easy to ask each other and say, guys, let's leave. But suppose the 20 of you are distributed within the stadium, each on their own. How long will it take for you guys to collect each other and now leave? You might only meet when the stadium must close. We get the analogy?
Yes.
Yes. So when the drug is so heavily distributed, then it is all over. And therefore, to eliminate it, the little fraction that leads to the gets to the excretory organs that is that which is eliminated. But a lot of it will be in other spaces. Good. So the last thing is drug clearance. We have drug clearance through metabolism and through kidneys and through others. So let's take care of that, and then we can call it a day. Someone to read that?
Drug clearance through metabolism. Elimination is irreversible removal of drug from the body. It involves biotransformation, that is drug metabolism and excretion. Once a drug enters the body, the process of elimination begins. The three major routes of elimination are hepatic. Slides zimepotea.
Sorry, hiyo simu yako Precious. Sawa.
It's okay, Precious, I can help you. Then
Of course, you have always come to her aid.
Then she can see
Please help.
hand.
Yeah.
Yeah. So elimination is a irreversible removal of drug from the body. It involves biotransformation, that is drug metabolism and excretion. Once a drug enters the body, the process of elimination begins. The three major routes of elimination are hepatic metabolism, the biliary elimination, and urinary excretion. Excretion is removal of intact drug from the body. Together, these elimination processes, they decrease plasma concentration exponentially. That is, a constant fraction of the drug is eliminated in a given unit of time. Metabolism results in products with increased polarity, which allow the drug to be eliminated. Clearance, which is CL, estimates the volume of blood from which the drug is cleared per unit of time. Total CL is a composite estimate reflecting all mechanisms of drug elimination, and it is calculated as follows. Basic formula: CL, that is the rate of eliminations, stroke plasma drug concentration. First order kinetic. CL is equal to the volume of distribution times K, where K is the elimination rate constant. V is the volume of distribution. So using half-life, I think you can take it from there.
Okay. Let's go back to the previous slide. We are having elimination, and the two most important things in terms of elimination are metabolism and excretion. The drug is biotransformed and then is excreted. In summary, what are the three major outlets? Hepatic, that's the liver. We know what biliary is. Hello? We know the biliary system. I need your confirmation.
No.
You know the things to do with the bile flow?
Yes.
Yes. The bile flows through the biliary system. In fact, that biliary is from the word bile flow. So that we are having those things of which ducts are involved? The cystic, the hepatic, okay? Until they bile into the intestines. And that's how it increases as they come out. What is the effect of elimination or excretion? Does it prolong it? Hello? If we increase the rate of elimination, what happens to the drug effect? Let's be here. When we excretion reduces, you know what half-life means? Yeah.
I think half-life is the time taken for a drug to decrease from the original concentration to half.
Yes. So when we are eliminating it, are we increasing the half-life or we are reducing the half-life? We are reducing the half-life, isn't it? Because when you eliminate it faster, then we get closer to its half of its concentration faster. How about elimination and the effects of the drugs? When we eliminate faster, do we prolong the effect or we reduce the effect? When we eliminate faster, we actually reduce the effect of the drug. How about elimination and concentration of the drug in the plasma? Reduce. The more we eliminate, the lesser the concentration of the drug. So that's just, those were the general points I needed to clarify. Now, in that slide, clearance is equals to rate of elimination over plasma drug concentration. First order kinetics. Clearance is equals to volume of distribution times a constant. In that constant, we have built. Hello.
You guys mnapiga kelele.
Okay, sawa, ni sawa. I think it's good now. Are you able to hear me?
Yes.
How had we gone through that slide?
Yes, just take it from there, using half-life.
So we are saying using half-life, clearance is equals to that 0.693. I had asked you guys, did you learn about Michael-Menten kinetics in terms of enzymatic action in biochemistry?
Yes.
So when I talk about his constant Km, you are quite clear about it. Then that doesn't make a problem. That is okay. So we see using half-life, clearance will be 0.693. This 693 is a K, is the elimination rate constant, times the volume of distribution divided by the half-life. Okay.